Welcome. Good afternoon, everyone. Thank you for joining us for part 9 of our refugee health webinar series. I'm making that number up. It could be more, could be a little bit less, but we're doing a number of these Thursday webinars on different topics. And today I'm really excited, and it's so timely to be sharing information on mental health for refugees and families. I'll just go through a few disclosure slides, and then I'll give a brief introduction of our presenters for today. So this is accredited for continuing medical education and social work credit. Bertie Polly, who is on with us today, will be sending out information on how to claim credit, but it must be done within 30 days of this event for the University of Vermont to accept that or to award you with credit. This is just a slide saying that there are no disclosures. We didn't take any industry financing, and neither of our speakers have any financial disclosures. And then this is just a slide to show that we have a website up. It is vtmd.org/refugee-health. And this is showing some of our older events that happened, but really we have a few more coming up, and then we're putting all of the presentations on there with the recordings, the links to the recordings, and a number of other key resources that Dr. Andrea Green, who has really spearheaded this webinar series and this project, has given to us. So a lot of information on that website. So without further ado, I am happy to introduce our speakers for today. We have Saida Abdi, who's a clinical social worker and professor of social work practice, working with refugee youth and families on trauma and resilience, and I believe is at the University of Minnesota. And we have Karen Fondacaro, who is the director of Connecting Cultures and the New England Survivors of Torture and Trauma. So thank you both so much for being here. And I'm going to hand it over to Saida, who will kick us off. And if anybody has questions while we go through, please type them in the Q&A, and hopefully we'll have some time at the end for questions. So Saida, off to you.
Thank you so much. And thank you for inviting me, Stephanie and Andrea, for organizing this. I'm very excited to be part of this conversation. Whenever I'm asked to present, and I'm not going to say more about myself, I think you've covered everything that needs to be covered. Whenever I'm asked, with the limited times we have in the West to present around mental health well-being of refugees and immigrants, I always know I will not have enough time. And so in reality, what I really want is to raise some questions in your minds as practitioners, and to sort of make you uncomfortable. I think it's much better for us to highlight what we don't know than what we know. And so this whole conversation, I hope, will be about just becoming more aware of when we have these models and trainings and certifications and clinical expertise in Western cultures, that what we don't know is much greater than what we know. And so in every encounter, and even in this discussion, if we really approach it in a way from place of learning, that is the most important thing. Now I'm going to share my slides, and I will not read through the slides, but just walk through, and hopefully there will be time for conversations as well. So in that spirit of being a learner and questioning what we know, and being conscious of what we don't know, one of the first questions I always ask clinicians and other providers to do when they meet clients from other cultures, including Afghan clients, is that these clients were not born the day they arrived in our borders or in our airports or in our communities. They have ways of being and living and healing and understanding psychological wellness and help-seeking behaviors. Really, the first question should be, what is in your client's cultural healing toolbox? In other words, question is like, where do people go for help before they came? When I meet a client from another culture, before I start trying to help, I actually ask them, tell me about this experience you're having. Nor if you were back home, who will you go to for help? What will they talk about? How will you express this? How will you talk about it? What will that person do? What will healing from what you're experiencing look like? And it is really important that as we move forward caring for those clients and those patients, that we're keeping in mind their healing toolbox, their pathways to healing, and that we're integrating that into the work we're doing. With Afghan refugees, you may think about faith, you may think about community, healing practices that are indigenous to those communities. I know about religion because in Islam, we use Islamic religion, Quran reading as part of the healing practices that is within our community, in Afghan community. So when I work with Afghan clients, I actually literally insert phrases and that are come from that culture, from the faith that I know is part of, from talking to them and from knowing from my own cultural background, part of the healing toolbox. So keep that in mind. The other thing to keep in mind when we see any patient, but specifically refugee patients like Afghans, is really to think about the experience of trauma and loss, and specifically migration, how people had to leave. For example, in the population of Afghans we're seeing now, had to leave in an instant, that they had no time to process the losses, that what they were leaving behind. And then once they come here, the shock of the loss actually hits, because where they were going is not where they have arrived. In their mind, they were going to America, this nation of plenty, all, where they will be welcomed because they are allies and so on. But in reality, what hit them is more trauma, more loss, more confusion, more uncertainty. So really to keep in mind, not only what was experienced back home, but the trauma, loss, and disappointment and confusion and uncertainty that people experience, and discrimination, and sort of like letting go of their expectations of what America will be like, and coming to terms with the reality of what it means to come to America, even in the neighborhoods in which you live, the houses that you're given, the help that you get, all of those things look different than what people expected when they got here. I know this from all my experiences for 20 years with refugees, Afghan refugees, and the ones I'm working with now with the community partners that I work with. So keeping those in mind is really important. And so not just talking about what happened in the past, but also what's happening presently. This is a model we came up with when I was at Children's Hospital. It's actually part of it's online, which is the core stressors, but I'm actually right now in the process of writing an article with a group of colleagues from across the globe. And we added this really not just identifying risk, but also focusing on resilience, because we can either reduce risk or we can build up resilience. And it's so crucial to build on the strengths of the communities we work with, not to again assume people have nothing to do and no place to go for the experience they're having, but actually say, tell me where you go to, again, that healing toolbox, and then building on that and saying that whatever I'm providing as mental health practitioner is not away from what you have already had, your strengths, but is building on your strengths. So thinking about trauma, again, with the Afghan population, actually, isolation is a big issue. Acculturation is huge. I mean, up to now, a lot of the questions and referrals I've really gotten were around young people who already are really having challenges in their homes with parental limits. Also, young kids who are in school, which is again acculturation, who actually have never been in school and starting 9th grader, 10th grader, because I have never had schooling, and how do we support them? Resettlement stressors, like I said, housing, big issue. The reason this is so important in psychological services is that the most important thing, if someone is facing homelessness, it is literally the most important thing. And if you say, I'm a therapist, I do therapy, so I'm going to help you with therapy, but I can't really do housing, you literally will have no impact on this family. There's no way you're going to help. You need to know who does housing if you don't. You need to focus. I was having this conversation with case managers actually in Michigan, because I'm working with a group in Michigan through another SAMS, a completely different SAMS project. And we were talking about this. And the question is, if people are so focused on how concrete needs, like basic needs, right? How do we do therapy? And you do therapy by supporting the concrete needs. You get to therapy by actually, because even, sometimes by just helping with the housing, actually, that's what my clients tell me, you may help you with the depression. But we cannot as clinicians say, I do trauma work and I do intervention. I know you don't say that, but sometimes that's how it sounds like because of the limited resources we have. But if we can really think about, I'm doing mental health when I'm helping with acculturation, when I'm helping with resettlement, when I'm helping with discrimination, isolation, loneliness, it is so important to engagement as well. This slide, I wanted to say this, I stole this from a colleague of mine, a friend of mine who presented with me, Dr. Mirzoy, some of you have met her, who is in Tulane. And I really love this because this idea of using help as a communication, like providing hope when you're doing mental health, empathy, language, like using people's language, even if you learn 3 or 4 words in Pashto or Dari, and just to welcome people, to talk to them in their language, to make them feel home. And actually this idea of partnership with community is so important, to build relationships with communities, to have cultural brokers, which is all some of you know is my thing. Again, to just step back and be really conscientious of, there is nothing wrong with the refugees. It's just we are asking them to function in a world that's very different. I use this, and I've had clinicians I work with actually put this on their walls, because it's really to say, when your client comes half an hour late, or when they expect you to do more than you think mental health services should be doing, it's not because there's something wrong, or they're doing something that they shouldn't be doing, or you are, but it is that this is how relationships look to them. And you as a clinician have been taught in a different way. And you or the refugee at this moment, when they arrive, Afghan refugees, who is going to change? You need to change, because they are new and they will adapt and learn, that we all do. But right at this moment, if you want to support this client, you're going to have in your systems of care to make changes and adjustments to build that relationship. So something like, we talk about boundaries, the boundary system in our systems of care is really very Western oriented. We need to think about how do we make them. So I'll give you the example that's very simple for me, which is when I come from Muslim cultures, like in Afghan cultures, people always give hugs to each other. I will tell you also one that is not across genders, but gender specific, that is very interesting about Afghans, is that they are people who love giving. And so when we have systems that say you cannot accept a scarf from a client, we are disempowering those clients. So to think about those. Cultural humility, I talk about this a lot because it's really, again, turn the lens on yourself. You are the one who needs to change. You are the one who needs to question yourself. You are the one who must always be conscious of the power imbalances that builds those relationships. That really good mental health support for refugees starts with self-analysis, self-awareness, self-critique, commitment to learning forever and ever, becoming a learner with ourselves. A key element I want everyone here to take with you is the idea of having cultural brokering, and that can be by partnering with a community, by working with your clinician, with your interpreters in different way. I can share even a manual that we've created of working with interpreters for clinicians and interpreters that actually expands how we work with interpreters. But there are times when interpreting is not enough, when you need to understand cultures better, to understand the nuances of relationships. Trust building begins with creating spaces where we can meet each other in a way that is open. It involves repeated and constant services, repeated and constant acts of being a helper, There's a lot of things that go into trust building, and it does not, it's a process. It does not happen one time. And just expanding our services. I have in the mental health systems that I work with, I have asked them to add a lot of things because it destigmatizes mental health. So you're not just coming for psychological support. This is where you go for others. I know that's not always possible. Relationship building, really paying attention to the relationship and so on. I'm not humility, accessibility, partnership, equity, those are things that are at the core of engagement. And if you're asking me about Afghan and other refugees, specifically Afghan, relationship building is so important that people must connect and make a relationship. To go to that again, safety, creating safer places, that means really safe spaces that are free of discrimination, of mistreatment. Think about culture trauma, and when you're working with kids, think about development. But connection is relationship, is safety in the sense of being respectful, making sure that you are training your front desk staff. Often we actually lose patients before they even get to the clinician because of the front desk staff, because the front desk staff are the way that they interact with these patients is disrespectful. And working closely with your interpreters, people from the community as partners. But really, this is, trauma 101 is create safer space, make connections, build relationships. And with patients, specifically from cultures that are collectivist cultures, where there's not this professional, you just go to a place for mental health, like in Afghan culture. And I worked with Afghans, I worked with them for many years, still connect to people I worked with 20 years ago. That's how the relationships are. The final things I will leave with you is be a learner, use the strength-based, as I talked about before, and really seek trusted partners to build relationships. Thank you.
Thank you so much, Saida. And Karen, do you want to take it away?
Sure, I'll share my screen, and you can already see why I enjoy working with Saida so much. Really a pleasure to co-facilitate some case management meetings with her. Here we go. Can you see this okay? I think what I have to say dovetails really well with what Saida just said. And also some of it is going to be a repeat. So, which never hurts because we learn that way. So I always start with, where is the country that the person is coming from? And this is just a picture of where Afghanistan is from, between Turkmenistan and Pakistan. And you can see right where Afghanistan is. And then one of the things I learned early on was lots of people want to call people from Afghanistan Afghanis. And that's actually the Afghanistan currency. So it's a really good piece of information not to do a cultural faux pas right from the beginning. And for some reason, it comes natural to lots of people to say Afghani as opposed to an individual from Afghanistan or an Afghan person. And as we discussed, just like Saida said, as we discuss a little bit of the history and cultural influences, really think about the possible impact on mental health, or what we really like to call well-being, because mental health has such a stigmatized name in the Western culture and in other cultures. So in Afghanistan, it truly has been the largest protracted refugee crisis, greater than 40 years of conflict. And then in June of this year, they had a very serious earthquake. There's chronic poverty, food insecurity, and of course, the pandemic is overlaid on all of this. And you can just imagine how this impacts mental health. 24 million Afghans in need of humanitarian assistance, with greater than 6 million being forcibly displaced by the end of 2021. And in the recent crisis, the U.S. Armed Forces withdrew, and starting in August 2021, over 80,000 Afghan evacuees arrived in the U.S. And I know that in Vermont, in the last fiscal year, we had about 290 arrivals, refugee arrivals, with individuals from Afghanistan being the majority of those individuals. And we are expecting or the plan is to have about 500 people come next fiscal year. Thinking about the cultural influences and considerations, I think what Saida said in terms of really having some cultural humility and listening to your clients is so important, and tend to use the word curiosity, being curious and having cultural humility, but it really is like a balance beam, because you want to listen and learn from your client about their culture and what their thoughts are, but you also you're there to provide a service. So you really do want to do your homework on knowing something about the culture beforehand and not expecting them to spend their time teaching you all about their culture. So to really do your homework plus being curious about what they're coming in with, and to remember that as we're learning about cultures, we want to avoid stereotypes. You're going to learn about a culture, but each person has their own individual characteristics and desires. And I think people can get into sort of learning about a culture and thinking, oh, okay, so all Afghans are that way. And to just be careful and to walk that balance beam carefully. Cultural context, as Saida said, is incredibly important. And I just wrote down a few of those things within a cultural context that become really important. So knowing some of the idioms of distress and resilience that individuals have from their culture. Let's see here. Knowing that refugee clients in general tend to present with more somatic complaints. So even if there's more of a well-being or a mental health concern, they may show up in a medical setting first, also because of the stigma attached to mental health. Also, as was said before, eye contact may be a sign of disrespect. And we have that thing where we say to our children, look at me in the eye directly, and that's a sign of respect. It may actually be a sign of disrespect in the Afghan culture. And then the meaning of mental health, when people think about what does mental health mean, we conducted a number of focus groups, and the most common response we got was that mental health means I'm crazy. So obviously it's stigmatized, and people really think about those folks who are on the extreme end of the continuum, who have like major mental illness or psychosis when they think of mental health. Cultural barriers to help seeking, things that help seeking in general may be something that is looked down upon in a particular culture. The importance of spirituality. And this is something, when I think of spirituality, prior to working with refugees, starting about 15 years ago, I did not pray with my clients. I did not really understand the importance of spirituality, but really being exposed to a number of different cultures, being open to many different beliefs and different ways of pursuing religion or spirituality as a coping mechanism, as something that builds someone's healthier well-being. To know about the holidays, Ramadan, for example, and also, as was said before, that to be aware of what the traditional healing practices are. So asking your clients, your patients, what would you be doing in your home culture? And then having curiosity, having that balance being going on, listening, and also being aware that you're bringing your own culture into the group. I learn this often when Saida and I are facilitating our case manager meetings, because it's often said that, like, what would Karen do if she was in this culture or that culture? And I have, it's really important to reflect on what you're bringing in. It's not just that someone else is coming from a different culture. You bring your own cultural beliefs, whether it's from your family, and many different practices around your own culture. And that takes a lot of self-reflection too. Also, just knowing the mental health rates of suicide. For example, we know that in the Nepali Bhutanese communities, they have rates of suicide that are 2 times the rate of someone in the US population. I've heard that some studies are coming out on Afghan individuals too. I think we're waiting for more studies to say anything definitive about that. So just a few more things about sort of the background of Afghanistan, or things to know, that Afghanistan is very multi-ethnic. There are about 42% Pashtuns, about 14 different ethnic groups, and these unique cultures and languages and traditions for all of these different ethnic groups. So really knowing who it is that's in your room. Also, that the conflicts arise due to differences in ethnicity and religious beliefs, which is pretty common for many of the refugee groups. And the Hazara, the Shia Muslims, have been oppressed for more than a century due to ethnic and religious identity. I do not claim to be an expert on Afghanistan, obviously, but I have, brought these things as a way to just have some background when you're working with someone from Afghanistan. There are two official languages, Dari and Pashto, or some people pronounce it Pashto. Farsi and Dari are similar in a written format, but they're very different when spoken. And when you're working with an interpreter, you want to make sure that you have the correct interpreter. So knowing which language and obviously the person in front of you. Collectivistic culture, very different in terms of an individual focus that we tend to have in the West. Collectivistic culture, you may have a whole family that comes in for services. And to also know that Islam is a religion of over 99%, with Sunni being approximately 85% and Shia approximately 15%. And what's interesting about the Sunni Shia split, let's say, is they both follow the Quran, but there are slight differences in the actual beliefs. With 85% of Muslims are Sunni, 15% are Shia. And to know who's in your room, because we have had this, I have a colleague, a graduate student I work with who is Shia, and we had a client come in who was Sunni, and they had a problem with her potentially being the clinician. So something to really be aware of when you're working with folks. And then some of the things to remember that are going to impact mental health too is the hierarchical culture. And again, you got to be careful not to be stereotyping, but knowing these things, that it's more of a patriarchal society, that there are roles for men versus women, and that this may impact if you prefer the same-sex therapist. And there are high expectancies of life in the US. There's diet differences. And again, as I said before, eye contact. Also very important to know that family is important, and that there tend to be large families. Polygamy is legal, but it's not supported or believed to be ethical by everyone who lives in Afghanistan. So that's important, not to think just because it's a legal issue that everyone believes that it's okay. Married men generally financially support the family, and women's roles are generally domestic, and children are expected to obey and respect parents. And sometimes that's a challenge when coming to the US when there are slight differences in parenting beliefs. At Connecting Cultures and Nest, the New England Survivors of Torture and Trauma, I wanted to give you just a very brief look at this before I go more specifically into the mental health services that we provide. We started providing mental health services, as you can see in the middle there. And we started initially with just psychological services back in 2007, and quickly learned about the need for housing and employment and all those post-migration living difficulties that Saida mentioned before. And so we really brought in a social work case management piece to our work, because it's almost impossible to do the mental health services when someone comes in. I think it was my first client that I had who was a refugee who said to me, I know I have that post PTS thing, but I haven't eaten in 2 days. And so I was like, I ran upstairs from my office and I got this gentleman a bagel. And I thought to myself, okay, this is going to be interesting. We really have to work on basic needs in addition to psychological services. We have grown since then. We have partnered with the Vermont Law School for legal services when we work with asylees. Also, we work with cultural brokers from ALV. We partner closely with ALV And we're hoping to share the case management going forward with a new grant that we've just gotten. And in physical health, we do have a psychiatry component, someone we can refer to, and physical therapy. And you are all aware of Dr. Andrea Green and the immigrant clinic, and we work closely with them. So as Saida said too before, that really thinking about trauma-informed care. And what is trauma-informed care? It's understanding the impact of trauma for clients, that you're looking through a trauma lens when you're doing mental health work, and that children and youth are not bad. Their behavior is not bad when they're maybe spacing out or they're not listening to the teacher. It may truly be that they're dissociating based on something they've witnessed. Very important to look through a trauma lens to understand their behavior and not just define it as bad and give it a consequence kind of thing. And the same thing with adults. Although in the Western world, we really have this book, DSM-5, filled with disorders. We look at adult refugee clients and patients as not disordered, and that they're having a normal reaction to abnormal circumstances. It's war and political conflict that's abnormal, not the people. And that is so critical for our work. Because otherwise we start putting the well-being and the mental health concerns within the individual. And interestingly, there are limited studies on individual refugees specifically from Afghanistan, but they tend to fall similarly with other refugee clients in terms of what it's really based on what's been studied, and what's primarily been studied is depression and PTSD. And part of it is the mental health stigma. But before really even being able to provide services, being able to make sure that there's a component to what your program does, if possible, to have outreach, to be able to go into the communities. We literally spent 2 years getting to know different groups before they started saying, I want mental health services, and would actually come into the clinic. So that is critical, and outreach continues to be like our number one variable that has to continue to happen over time. But if we do look at the mental health studies, the most common Western defined mental health concerns are post-traumatic stress disorder. Again, from other cultures, people do not use that term necessarily. 31%, this is a recent, really good systematic review and meta-analysis that was done in 2020. 11% meeting diagnostic criteria for anxiety, up to 80% for survivors of torture. That's a whole other talk. Depression, 31.5%, and up to 45% for individuals from Afghanistan. Again, I said somatic symptoms, and also we see a lot of alcohol and substance use, and alcohol and substance use go along with trauma. You need a holistic lens. Again, not a disorder to be fixed, very critical. Also, it's not all in the past. They're dealing with past stressors and current stressors. There are things still happening in Afghanistan. There may be family members that are still in Afghanistan. It's important that we're looking at both of those. Can you tell me, Stephanie, how much more time I have? I don't.
Yes, it's 12:50, so you have a few more minutes.
Okay. Is 12:50 the time I'm supposed to stop?
Nope, you have 5 or so minutes. I don't
Okay,
see
good.
questions yet, so
Okay, good. Well,
keep
I
on
mean, I
going.
could go on longer, but here we go. So I'm just going to like touch on what I think is really important, is that in Afghanistan, people do not describe just depressive symptoms as something wrong within someone. They do see them in the context of social problems. It's a reaction to situations rather than a medical or biomedical problem. So they may say that it looks like somatic distress or thinking too much. And interestingly, some of the causes of depression that a study was done on a number of narratives with Afghan refugees, and that it was the cause of the depression is pre-migration traumas, separation from family being the biggest one, and also post-resettlement stressors, loss of professional identity. We know people who have degrees in medicine and they can't practice here and they're working as a janitor or in another job that does not is not as fulfilling as they might have had in Afghanistan. Loss is one of the biggest precursors to some of the mental health concerns. Here are some mental health terms. And then what I wanted to say is that this is what we see in the room. Number one, resilience and strength. Amazing. When you work with refugees from Afghanistan, from other cultures, it is amazing what people have experienced and the strength that they come in with. So it's really important to use a strength-based approach, and that they're grieving loss of family members. They're dealing with poverty, language barriers, the new culture, unemployment, loss due to the pandemic. They may have trauma or torture experiences specifically, and traumatic stress. So we have developed a model that really helps guide some of our strength-based treatment. And what I'm going to show you very quickly is that if you just look at things through a post-traumatic stress lens or a depression lens, you're only looking at the individual. You're only looking at how the past in a post-traumatic stress situation impacts the individual, and you're only looking at traumatic stress symptoms. We think it's important to look at these post-migration living difficulties and daily stressors, to also add that we're looking at wellness. Obviously, I can say a lot more, but from that model, we have developed a biopsychosocial spiritual treatment. And these are the modules that go with the treatment. I'm not going to be able to go into them, but we start off with the cultural context and asking people, what's your view of mental health? And there are a number of modules. We have a published article on this. We also, through an NIH SBIR grant, developed a language-free, culturally responsive app. And this is just some pictures of it, but it has the app goes along with the modules that we developed. And for the treatment, I'll give you an example. For the first module, we have that introduction and respectful discussion about mental health, and with an emphasis on strength. We have a discussion of torture and trauma and idioms of distress and what are people's words around that. And we really validate that this is a normal reaction to abnormal events. We also try to learn their language from 1 to 10, and it's a little bit challenging when you have over 70 languages, but we're getting there. But it's really helpful to know some words in your client or patient's language. And then for the module, we do an avatar, and there's also a guided deep breathing. So that's for the first module. And then we do, as part of the treatment for those individuals who are having flashbacks and having more difficulty and they want to tell their story, we do what we call narrative exposure, but it's like an exposure light, because we give the individual control over timing and whether they want to tell their story. I'm not going to be able to go into each of the individual modules now, but I'm just going to go back to putting up these 10. We spend a lot of time on safety, values, rather than what's wrong with you. We say what's important to you. Behavioral activation, really helping people to engage in their lives despite the horrific events they've gone through. Coping skills, sleep hygiene, working with thoughts, acceptance and tolerance of emotions, narrative exposure, and life path exercise. And then we have a big celebration. So I'm going to stop my share there. And thank you.
Fabulous. Thank you so much. Thank you both, Saida and Karen, for a fabulous presentation. So much information and so much to think about when you're working with your patients. I know, Andrea, do you want to unmute and ask a question? It could be that because, Andrea, you're a panelist currently, you may not be able to type in the Q&A. So I don't know if you had a specific question, but if others have questions, please feel free to write them in. Go ahead.
This is Andrea, and I just want to thank you both for an amazing talk that sets everything in perspective. And I wanted to ask a little bit about the use of cultural brokers and community health workers. And I fully appreciate the value of social workers to meet basic needs as first and foremost, and the value of using interpreters who can take on a little bit of that cultural broker lens. Having community health workers has been really challenging for us. It's something we've been working on. And I wondered, what have you found as ways, if you wanted to have a community health worker who supported your practice in really navigating culture and in helping with health literacy and helping with reducing stigma and creating a culturally safe environment, how have you managed to make that happen? How have you financed that is basically my question.
I will begin if that's okay, Karen.
Yeah, absolutely.
Because I have actually done that, as you know, both at big hospitals. So when I was at Mass General, which is actually where I started using with Afghans and other populations, there are multiple ways we funded. I would just tell you, like when I work with an organization that is trying to integrate, whether you call them community health workers, cultural brokers, cultural liaisons, whatever term you want to use, but we know what they will do, like we know the tasks. We map the resources that's available. I will give you an example of the diversity of those resources. When I was at Mass General Hospital, they were actually funded through what's called the Community Benefits Program, which is a program that's funded by the hospitals as by law, because to keep their tax exemption. So that was money that was put away. And once we came up with this idea that this was really important, addition to expand. So when I started at the health center that was part of Mass General, they were having so much challenges with engaging refugees to all kinds of healthcare. And when myself and the other group in the community health program that we together worked on, including, it's now a huge part and nationally, actually a national model for integration of community health workers. On the other hand, there are places like, say, in Maine, it is more, and even in Massachusetts, other parts of Massachusetts, the community health centers that don't have that access to that money, it has been using the funds that are available through behavioral health. So it's really looking at, they can be grant. It may be that you start with grant money, which is another model we've used, is you start with the grant money, show efficacy and usefulness through the increased access and through increased engagement. Our patients, actually a doctor did at Mass General Hospital at the health center, did just chart review between refugees and native born Americans, and found that our refugee patients with that addition had higher level of show-up rates, adherence to treatment, staying, like literally, it showed an outcome that the hospital understood in numbers. And so we sometimes use funding through foundations, through state grants, through city grants, but also through working with your public health agency. One of the things we did in Massachusetts, actually, our Office of Refugee Resettlement fought very hard. So funds that were going to be, once there was a change in our behavioral health funds, how to reimburse, that refugees were added as a group that will have case management. So Andrea, I know that's a long answer, but looking at your system and seeing where funds are available, and then you build up that awareness and acceptance of this service as being a huge part of health access and health equity.
And I would just add, I mean, I think the TSTR program that Saida has developed with colleagues, we work closely with Connecting Cultures and ALV, work closely where the cultural brokers and the clinicians get trained together, which is just, I think, a beautiful model. And then looking at how they are a team in providing this service is, and it's something that's really made me think about for adult clients, rather than just having someone as an interpreter and being that sort of, direct translate, to really make it a team where the interpreter is the cultural broker and works together and is trained just as the clinician is. And obviously they'll have different strengths in different areas, but the respect in that relationship is also critical to the well-being of the patient.
Thank you both very much. And I think that also speaks to the fact that there's a lot of work in our state to integrate. We have a lot of integration in primary care because, as you both have said, so much mental health happens in primary care because of the stigma and because it's the place of access. And so I love thinking about these models and these collaborations and ways to break down silos and learn from each other and create teams where we can meet people where they're at as opposed to where we ask them to be. So thank you very much. You both have so much to offer. And I know that it's really, really helpful to change frames of thinking for us so that we can serve people better.
Can I just add one thing, Andrea? And I'm willing to talk to you more about I've done this now in like 5 states and Canada. The Canadian government's right now really like committed to funding this because we had 5-year project that was an impact evaluation. I can talk to you more, but I think, I tell my colleagues who are thinking about doing cultural brokering that we have 2 different conversations. We have the clinical conversation about the clinical value to having, as Karen said, an integrated system of care that brings culture and clinical as an integrated rather than separating, which is very Western, the separation. That's one. But I think for clinical providers and funders and Department of Public Health, it's not just about that. It's also about that I always say to the leadership when I was in hospitals, it is really helping you achieve the goals. Like, what do we want? We want patients that are accessing healthcare. We want patients that are actually stay engaged in their care. We don't want, one of the things cultural brokers do is actually really improve treatment adherence because the client actually understands in a way that makes sense to them, the patient understands in a way that makes sense to them what kind of treatment that they're getting, why they're getting it, why it's helpful, how they can be partners in that treatment instead of just being told to do. This is not even about cultural brokering, but my cousin who is young, much younger, just started a nursing job. And she was telling me this experience what she had with the patient, where the patient was actually, and I had many of those, but this was just came to me. The patient was absolutely refusing all medication. And then she started talking to the patient in Somali and explaining things in a way that was not like interpreting where she was just looking at a provider, but she was actually having this conversation. And then the client said, okay, I understand now what I'm doing. And cultural brokering is also breaching relationships. So that you, Andrea, and I know you know this, you leverage all that relationship that cultural brokers have in the community for the clinical services.
And so I would just add that also having the clinician give the cultural broker permission to tell them when they're not being culturally responsive, so that so there's really sort of respect within that relationship too. And it's not just like the cultural broker thinking, oh my gosh, that person's off and doing this incorrectly, but that they have an open dialogue about it too.
Well, thank you. And I will be in touch. I do have 3, we call them family strengthening workers for the past 3 or 4 years, and funding them is always a challenge. And the state of Vermont is really looking at community health workers. So we can have a full other conversation where I would love to bring you into on a state level. So stay tuned. There is a community health workers, I don't know the date, but we'll try and make sure it comes out to everybody in the Vermont Medical Society. But there is a big workshop coming up in the state because this is a place that the state overall is looking to try to do more of this. So we will definitely harness your expertise in that area. And thank you very much. We're a little bit over time. So I just want to thank you. I love, as I say, these reminders and this way of approaching taking care of our new arrivals in the state and making sure that we're taking good care of them and meeting them where they are, asking them what they had before, and how do we make sure that we're giving them what they need in order to be the strong people that they are. So thank you very much.
Thank you.
Thank you all. Thank you both for the work that you do. And thank you all for joining us. And we will see you at the next webinar. So thank you so much.